Good evening, everyone. I'm Mac McCorkle, Director of Polis, Center for Politics at Duke University. I'm delighted to welcome you to our very first event of 2021. As the Sanford Schools and Duke University's Politics Center, Polis works to increase our understanding of politics by promoting cutting-edge research, fostering rich political discussions, and helping a new generation of leaders find on-ramps to public service. This evening, we're honored to have Professor Mark McClellan and Professor Tyson Brown with us for a discussion of the reality of COVID. This event is part of the Polis Innovation Accelerator, which works to help students produce bold solutions for our most pressing political problems. I'm going to turn it over now to Morena Martinez, our Polis PhD fellow, to say a few words about the Innovation Accelerator and to introduce our moderator. Morena?
Good evening, and thank you guys so much for joining us as we launch the Spring Innovation Accelerator Speaker Series. Each year, the Innovation Accelerator will offer speaker events and workshops centered around a particular theme. The goal is to encourage people to think up bold policy solutions to today's biggest political problems. This year, the theme is Justice and Citizenship in a Time of COVID. Last semester, we hosted illuminating conversations with experts on structural inequality, mail-in voting, and leadership. And we're pleased to continue these conversations this semester with talks on topics like education during and after COVID-19 and the future of the US healthcare system. We are also very excited to announce that we will host our very first policy solutions competition this semester. It will give undergraduate and graduate students an opportunity to compete for prizes by crafting innovative policy proposals to address challenges related to racial justice, the COVID-19 pandemic, climate change, and voter participation. For more information on the policy pitch competition, upcoming events, and videos of our previous events, please visit our website. You can find us at polis.duke.edu. For tonight's event, we hope that you'll be thinking of questions that you'd like to ask our esteemed panelists and enter them into the chat. You can go ahead and send them to me, and I'll turn to them during our Q&A segment later in the hour. To kick things off, I'm delighted to introduce our moderator for today's events, Professor Deandra Rose. Deandra Rose is an assistant professor of public policy, political science, and history at the Sanford School of Public Policy. She's also director of research for Polis. Her research focuses on American political development and the relationship between higher education and democratic citizenship. A summa cum laude Phi Beta Kappa graduate of the University of Georgia, she earned her MA and PhD in government from Cornell University. Please welcome Professor Rose.
Thank you so much, Morena, and good evening, everyone. Welcome to our very exciting event that we're having today with two superstars from Duke University. So I am very pleased to introduce Mark McClellan, who is the Robert J. Margolis Professor of Business, Medicine, and Policy, and the founding director of the Duke Margolis Center for Health Policy at Duke University. Dr. McClellan is a doctor and an economist who has addressed a wide range of strategies and policy reforms to improve healthcare. Dr. McClellan is the co-author of a roadmap that details the steps needed for a comprehensive COVID-19 response and safe reopening of our country. Before coming to Duke, he served as a senior fellow in the economic studies at the Brookings Institution, where he was the director of the Healthcare Innovation and Values Initiatives and led the Richard Merkin Initiative on Payment Reform and Clinical Leadership. Dr. McClellan is a former administrator of the Centers for Medicare and Medicaid Services and former commissioner of the U.S. Food and Drug Administration, where he developed and implemented major reforms in healthcare policy. He has also previously served as a member of the President's Council on Economic Advisors and senior director for healthcare policy at the White House. And he's also served as Deputy Assistant Secretary for Economic Policy at the Department of Treasury. Professor McClellan was previously an associate professor of economics and medicine with tenure at Stanford University and has twice received the Kenneth Arrow Award for outstanding research in health economics. So welcome, Professor McClellan.
Thanks, Deandra. Good to be here with you all.
I'm also very excited to introduce Professor Tyson Brown, who is an associate professor of sociology and the director of the Center on Health and Society. His program of research examines the who, when, and how questions regarding ethno-racial inequalities and health and wealth. Dr. Brown has authored numerous articles in leading sociology and population health journals, and his research contributions have been recognized with awards from the American Sociological Association. Professor Brown was also the recipient of Duke University's Thomas Langford Award, which is very prestigious, and was a resident fellow at Oxford University from 2019 to 2020. In addition, he has been awarded funding for his training and research from the Robert Wood Johnson and Ford Foundations, as well as the National Institutes for Health. So thank you so much for joining us, Professor Brown.
Thank you so much for having me. It's an honor to be here.
So to start off, I have to ask a question that I'm sure is on the minds of many in our audience who are, of course, stepping back and remembering, oh, we have a pandemic that we're grappling with at the national level, the state level, and globally. But also this occurs here in the US in the midst of some pretty substantial political turmoil. So I'm wondering, I'd love to hear, anything that's on your mind, particularly related to, one, bandwidth for grappling with the pandemic, especially as we think about the possibility of moving toward impeachment proceedings in the Senate. Might that mean that lawmakers have less bandwidth to grapple with the pandemic? And then two, just thinking about how political the pandemic has become, and even things like mask wearing. So, we have all these images from the attack on the Capitol where we see a number of protesters, who are walking around without wearing masks, or thinking about lawmakers who are evacuating the House chamber, the Senate chamber, and being sort of put in situations where their colleagues may refuse to wear masks. So I would love to hear, anything that you're thinking about related to the pandemic and the current political moment.
DeAndre, you want me to start, or
Mark, if you would, thank you.
Yeah, happy to. It has been a really tough week, and remember on December 31st, we were all looking for, 2021 is going to be brighter. It certainly still feels like, DeAndre, we're in 2020. Like, I guess this is like December 42nd or something like that. So the same issues. And I think you're absolutely right that but for these unprecedented actions in Washington last week, the attention would be even more on the pandemic right now, let alone with what Congress is going forward and doing. People probably don't know that just about every day this week, we've set new death records due to COVID, over 4,400 today. Cases in many parts of the country are the highest they've ever been. There's some concerning variants of the virus out there that may be harder to control. And you haven't seen that as much in the news because, as hopefully most people know by now, President Trump just got impeached again, sort of a big reflecting the considerable attention to this issue. And there have been some, to your question about logistical political implications. Impeachment trials in the Senate do take up bandwidth and oxygen. You saw it happen last year with the first Trump impeachment. That was a couple of weeks when the Senate wasn't moving forward on anything else. And while this is a somewhat different dynamic from a political standpoint, this isn't just partisan. There are, I think, 10 Republican members of the House who voted for impeachment this time. And I would say, I expect there could be as many as a dozen Republican senators based on the way things look now. That would take up some time at a critical time for the new administration. As you know, when administration starts, that's probably the best moment you're typically ever going to have to get your legislative agenda accomplished. President Biden ran on a lot of things, but above all else, he ran on helping the country through this unprecedented public health emergency and the economic implications of all that, economic implications that have disproportionately affected some groups of Americans. So I think they're going to keep that focus number one. There was actually some discussion among some of the Senate leadership about whether the trial might happen a little ways down the road, get through the first 30, 60, 100 days with the needed legislative actions and other supports that were the president-elect's number one priorities during the campaign and then turn to it. I don't know how feasible that is. But one thing that makes this more doable is, ironically, the impact that President Trump probably had on the Georgia Senate races. People have made a big deal about how evenly divided the Senate is, and that does affect what legislation can pass. I think any major legislation, especially on issues like healthcare, more generally, public option, et cetera, are tough when you have very divided Congress. Even if you're in control of if the president's party is in control of the Senate. So those steps may be difficult, but it's hard to convey just how much easier life is when the Senate agenda is set by your own party. And that means that judicial appointments are going to get, executive appointments for the new administration are going to get scheduled and voted on quickly. It means that judicial appointments as they come up are going to get voted on, things that otherwise might take a long time, be dragged out. I saw that the last time when there was a Democratic administration and a Republican Congress. Those things can all go faster. So Chuck Schumer and soon to be President Biden are going to be very good friends, and they're going to figure out a way to move forward with the impeachment trial. If you're really saying it's that important to the country, it's hard to see just putting it off 100 days. But the flip side is you also can't put off the overall agenda. It is going to be a very challenging first 100 days to get both of those issues addressed. But that's what I think the president-elect has to do.
Thank you so much.
And on your point about masking, just to add on to that, that absolutely has become a political issue. 30 percentage point differences between Republicans and Democrats are larger in masking rates. I hope as we get into a different political environment in Washington that hopefully will be a bit more bipartisan. I think hopefully people have been a bit sobered up by what happened this past week, that we can move beyond that. One of the main things that you can do as a president is set a tone and do things that do have an impact, maybe not on everybody, but on culture. I'd like to see, even though everybody already knows it, what are some bold initiatives that the administration could take related to masks to try to make that a bit less political. Something like the administration's already talked about mask requirements in all federal places, transportation, et cetera. Maybe we can just distribute a lot of high quality masks to Americans who might not have it. Just things that, and talking about this regularly, steadily, hopefully with support from a lot of the Republican leaders around the country. I just was working recently with Governor Abbott in Texas. He doesn't see eye to eye with the president-elect on a lot of policies, but they have a mask mandate that they're struggling to enforce. They want to work more on that together. A lot of other Republican governors do too. So I think there's an opportunity for doing something better. And anybody had any doubts at all that it made a difference, as you said, a lot of people in the riots last week, the insurrection into the Capitol, weren't wearing masks, and we now have some legislators with COVID as a direct result of that. So it does really matter.
Wow. Thank you so much, Mark. And Tyson, I know your research focuses on disparities, and you've done work on the disparate impact that COVID is having, especially on marginalized communities. And when Mark talks about mask distribution, I can't help but to think about this image from the last couple of days where you see Congresswoman Lisa Blunt Rochester from Illinois working to pass out masks to her colleagues, as they're sort of quarantining, they've evacuated the chamber together. And, there were some people who were like, yeah, no, thanks. I'm not wearing a mask. Please help me make sense of these people, Tyson.
Oh, well, I don't know that I can, that's a tall order. But I think you're exactly right. And I agree with everything that Dr. McClellan said. And I do think that this is a critically important issue. We do know a lot more about the virus than we did just 3, 6, 9 months ago. And we know that masks are one of the most efficacious ways that we can keep people healthy. And so from a public health standpoint, this is really key. And I think as much as we can encourage buy-in, that's a good thing for, because this is a contagious disease, it affects us all. We all are in this to some degree together. And so the weakest link is a real threat to the health of the rest of the nation. And so, and of course, this also has political, economic, and social implications as well, right? And so in order for our economy to really get back to normal, we need to get these rates a little bit lower. And so I think these are really critically important issues. I don't know that I can make total sense of why people are refusing to wear masks, but it does seem tied to a very particular brand of identity, politics, and a sort of radical ideology that rejects any sort of prescriptions from the government in the mood of sort of this rebellious free spirit, don't tread on me sort of ethos that I think that right now it's particularly harmful.
Thank you so much. Can I follow up with you, Tyson, just to ask about, the magnitude of this pandemic? And, I think many people would agree that this is unprecedented. It's, we've never seen anything like this. But from your perspective and your research, what's wowing you?
Well, there's a lot. This is truly, the word unprecedented has been used a lot in the last number of years, but this is truly unprecedented, right? So as of now, we're at 23 million cases in the US. We're at 381,000 deaths in the US. This is huge, right? And the impacts are deep and broad in terms of health, as well as political, social, and economic impacts. And it's cuts across all segments of society. We also know that certain segments of society are particularly hard hit. In particular, we can think about Black and Latinx communities that have had disproportionately high rates of COVID cases, as well as mortality. So estimates suggest that Blacks and Latinos experience 2 to 3 times higher rates of death from COVID than their white counterparts. And this is consistent with this old adage that, when America gets the cold, Black America gets pneumonia. And we're seeing this play out in real time, and the consequences couldn't be more serious. And this is truly a public health crisis. And to speak to your points earlier, we're really facing these twin crises right now, right? A threat to democracy, and then also the threat to the health and well-being of the American population. And I certainly hope that we're able to, so to speak, walk and chew gum at the same time, and have the bandwidth to address both of these things that are both really serious to the health of the nation, in my opinion.
Mm-hmm. Thank you. And Mark, I wonder, can I pose the same question to you about, from your perspective, thinking about the magnitude of this, what should we be thinking about? Like, if we really want to wrap our heads around what a big deal this is.
Well, yeah, the magnitude is hard to convey. This is the biggest public health emergency in terms of numbers of deaths since the Spanish flu pandemic back in 1918, so well over 100 years. That one had 2 big waves and no effective treatments or vaccines. So we're not at those levels of deaths and impacts on the population, but we're going to be over 400,000 deaths before inauguration day, on track to surpassing the number of Americans who died in World War II and the Civil War before this is over, with this continuing big surge. And this is a global event. The U.S. has had it particularly tough, leading the world in numbers of cases and deaths, but it's getting to be very challenging in other countries as well. England is on lockdown now. Much of Europe is seeing yet another surge in cases, and we're seeing more rapid spread in parts of the world that had been spared before this winter, including essentially summer outbreaks that are huge in places like South Africa and Brazil. That's really worrisome. In terms of response, it's also been very hard to deal with because of the scale. You know, the good news in all of this is that we're now living in what I think has clearly been demonstrated to be the synthetic biology age. So despite efforts by the Chinese government right at the beginning to block information coming out about the outbreak itself and about the nature of the virus, thanks to some essentially entrepreneurship by Chinese researchers. The genetic sequence of the virus was published by late December, beginning of January. Within 10 days, thanks to modern molecular testing technology, very accurate tests for detecting the virus were available, thanks to the synthetic technologies around making essentially human antibodies, stuff that you produce naturally in your body to neutralize viruses and other infections. We had those monoclonal antibodies available by spring and getting into testing. And as you know, made incredible progress on making vaccines available within less than a year of even knowing this virus existed. But the problem we've had is scale. Dealing with the problem at this scale where hundreds of thousands of people probably were infected before we, at least tens of thousands before we even noticed it, because we didn't get testing out on a large scale in front. In the first surge, inadequate PPE, inadequate ventilators was a problem. Later on, it's been testing at larger scale. So that's been unevenly available and certainly not reliably available to help protect essential workplaces. Last month it was therapeutics. We have monoclonal antibodies that I think evidence pretty suggestive work well. Those are still very hard to get, and we're living through that right now with access to vaccines. And to Tyson's point, when there are issues around access to needed technologies, access tends to be uneven. We've seen that in our health system, even more so than, we're seeing inequities happening across the world, but more so here. And every single problem that we had in responding to the pandemic, I think traces back to these same couple of fundamental issues of being prepared enough to be able to respond at scale and to respond at scale for all parts of our population.
Ask a quick follow-up on that, on the preparation point. I think that's so important. Can you give us a sense of I guess, the extent to which we were prepared or unprepared for this, and what might perfect preparation, or something that's more perfect in terms of preparation, have looked like?
That's a
Oops. One moment, Mark. Let's see. Oh.
Been there. Okay, great question, 𝗣cie. We were clearly unprepared. We thought we were prepared, so we were maybe unprepared in a prepared sort of way in some dimensions. We did have a stockpile that included some of the equipment that we needed, some excess PPE, some excess ventilators, but it was kind of based on what we had prepared from previous pandemics. And this has happened a lot in US history, just in my time in living through US history. I was FDA commissioner during, I was at the White House during 9/11, FDA commissioner during the SARS outbreak, worked some on the H1N1 flu pandemic from 2009. Every time after those outbreaks, there was an increase in congressional appropriations for what we thought we needed. So national stockpile, mechanisms to support the development and availability of countermeasures and the like. But then over time, even if it's just a few years, those preparations tended to go away. Some of the institutions that had been established after the 2009 flu pandemic, which was not nearly as bad as this one in terms of affecting so much of the world so greatly. Some of those institutional supports, coordination across HHS and the White House, those went away in the subsequent years. And so we weren't as prepared as we could be in dimensions that we kind of knew about, but we also weren't really keeping up with the technologies that could enable us to be even more prepared. Just as one example of that, I mentioned access to testing. So, the technology was there for these so-called PCR laboratory tests to detect the virus, couple that with genomic sequencing, you can even detect kind of each particular variant of the virus. But through January and then through February, it really wasn't until March that we started doing any kind of testing beyond at a sort of limited scale at CDC. So because of that limited capacity, CDC was saying, well, you got to send the test to us if you from someone who you think may have been exposed, and because we can't do that many tests, we don't want to see it unless they come directly from Wuhan, China, or at least the China area. We know now that there were by March, again, tens of thousands of cases already in the US that had been chalked up to pneumonia, or because this virus is so insidious that hadn't even led to symptoms. So by that time, it's awfully hard to do containment. We've been kind of running behind ever since on testing. I guess the other thing I'd add is that what you want to put in your stockpile is not just the glittery medical countermeasures like the capacity to build up-to-date tests or the antimicrobial agents that you think might be useful. It's whatever is the most weakest link in the supply chain, and that'll typically be a product that's really generic, where there's like low profit margins on being able to make it. So there's maybe one or two really big companies that are making it, and they're typically companies located outside the United States because labor costs, et cetera, tend to be here. And that was the case with masks. That was the case with pipettes and tips that are needed to do each of those laboratory tests. It's kind of turned out to be the case now, not just for vaccines, which are complex to manufacture, but the syringes and some of the other finishing products that are needed alongside the vaccine. And so for the future, I think we're going to do a couple of things differently, I hope. One is pay attention to whole supply chains and making sure we've got more reliable access to supply, hopefully a good bit of it either domestic or very secure for future pandemics, that we could ramp up much faster than we did. Second thing is just really recognizing that we're in a new era of pandemic response, where the expectation should be that we'll be able to identify the agent that causes the infection right away in a matter of days. We know we can do that. We did that in China as soon as people started paying attention to this rather than covering it up. Second is we know we can make synthetic immune antibodies to help fight the virus. We need to have a bigger capacity to do that fast. And then third, we had really a remarkable response, I think, for the most part, for the research and development of vaccines. And we can talk more about that, but I don't have a whole lot to fault there. Very large scale production, lots of attention to really using sort of the Defense Production Act equivalent to get big 40, 50,000 person trials done that weren't just done in big academic medical centers, but that enrolled proportionate to disproportionate, not less than proportionate numbers of people who are at high risk, frontline healthcare workers, people from minority backgrounds, elderly individuals, enrolled them in trials and complete really good trials all the time, at the same time doing large scale manufacturing before we even knew if the vaccines would work. That all was good, but where we've really fallen down is in the federal state handoffs. When, if there are tests available, if there are vaccines available, how do we make sure we get those distributed the last mile? Get the test, as Tyson was saying, to the people who need it the most, get the vaccines into arms of people who need it the most, when there's a lot of distrust born out of some of the political environment that we're in, that we talked about earlier. So those are the kinds of things that need to be done differently next time. And we, frankly, this time we're not done with this one yet. And in one form or another, I think COVID is going to be with us for a while. So hopefully that'll keep reminding us, a silver lining here, just how important it is to be more effectively prepared.
Well, I was taking notes. I'm sure everyone else here, they were also taking notes. So we have to be ready next time. So Tyson, if I can turn to you, last semester we hosted a conversation on structural inequality, and Professor Jay Pearson told us that structural inequality is characterized by a set of social arrangements, relationships, and conditions that are informed by biased public policy decision-making. And it manifests as stratified social hierarchies of differential human valuation. Like, it was a mouthful. And I wonder, can you help us again to revisit that conversation? And as, this sort of inaugural event of our semester, and we're continuing to approach this idea of structural inequality and thinking about that as we consider our big problems, can you help us unpack that definition?
Yeah, well, thank you. I think that's really, I couldn't agree anymore. And Professor Pearson is certainly an expert on this topic. Yeah, I think that this idea of structural racism has often been seen as very abstract and nebulous and slippery, if you will. And so I do think that it's really important to have some conceptual clarity about exactly what that is. And ultimately to measure it, right? Because the idea is that you can't change something if you can't measure it. And so when I think about structural racism, I would just add that that it ultimately involves a few things. One is that it's multifaceted, it's interconnected, and an institutionalized system of relational subordination for people of color and superordination for whites. And so by multifaceted, I mean that structural racism is manifest in a wide array of societal domains, including political, educational, criminal justice, and social and healthcare systems. And by interconnected, I mean that the various domains of structural racism are ultimately linked and mutually reinforcing across domains. So, for example, residential segregation, we know, shapes racial exclusion and subordination in many other areas of life, including education and employment and political representation. And the structural racism is also institutionalized. And by that, I mean that structural racism is obviously embedded within institutions, as well as organizations such as schools and hospitals, jails, and companies. And also a central feature of the US is a racial hierarchy in which Blacks are subordinate and viewed as inferior, while whites are superordinate and considered superior. And so this ultimately results in the inequitable distribution of power, resources, opportunities, and risks along racial lines. And these things we know are powerful determinants of population health.
If I could just add to that, I think the evidence is in the process of bearing out just how important those structural differences are. So going into 2020, we had, as a consequence of some of the things that Tyson was talking about, these big racial, ethnic inequities in things like life expectancy, rates of chronic diseases, and the like. And if you look at what's happened since then, where because of these structural differences in exposure to risk, as Tyson's written about, exposure to risk, opportunities to get treatment, and also impact of COVID because of these pre-existing conditions that were also disproportionate. Overall, what you're going to see in 2020, unquestionably, is the life expectancy in the United States go down, but it's going to go down at an even bigger differential rate because of what we've just been talking about: the differences in exposure, the differences in impact of exposure, and the differences in treatment. And that is why what's going on right now and going forward with vaccination is just so critical to get right. I'm worried that we're on the same track for reinforcing those differential impacts right now.
Can I stay on this topic of vaccines? Because I'm really thinking about, if this is one place where, if history is to be a guide, we might expect, as you say, Mark, looking forward, that we'll see these disparities play out in important and substantial ways. When it comes to vaccine distribution and access to it, or even inclination to be vaccinated, do you anticipate seeing substantial variations in terms of various subgroups in the population?
Yeah, and it's not because there isn't any effort or attention being paid to the fact that these health disparities exist. I mean, we know that, and we know they've gotten worse in recent years, It wasn't for COVID, but in areas like cardiovascular disease and the like. But what's happened here is a lot of effort directed towards guidance that could potentially address disparities and policies that could potentially address it. But we're kind of being reminded of how hard it is. And I think that hopefully is going to lead to some real fast thinking in the next month or two in real time to head off what, again, I'm predicting are going to be worsening disparities on the course we're on now with vaccines. So as I talked about, record pace of developing vaccines. Thank God we're living in the era of synthetic biology where we've never produced a vaccine for anything like this timetable before in human history. Shortest before, I think, it's something like 5 or 6 years. So we're at less than 1 here with literally hundreds of millions of doses that are going to be available in the US in the next few months, billions of doses probably in 2021 across the world. That's fantastic. But when we came to the point of thinking about how do we actually get these vaccines distributed, we did a couple of things I think helped. One was recognize that there are financial barriers, that there are other barriers, but there are financial barriers to getting treatment. So Congress passed legislation, bipartisan support early this year, that any vaccine must be covered by any health plan, and the administration costs for that vaccine must be fully covered. And for people who are uninsured, there's a mechanism for states to get those costs reimbursed as well. So nobody should have to pay anything out of pocket to get vaccinated. On top of that, we had an expert advisory group at the Centers for Disease Control, their advisory committee on immunization practices, which includes some diverse representation, a lot of attention to ethics, focusing on, well, who should get the vaccine first in terms of risk prioritization. And obviously part of the goal, not the main goal, in terms of prioritizing something that's in limited supply is to make sure you're getting the most welfare benefits from it. Now, they made an explicit decision not to include race and ethnicity explicitly in their goals, but they did include things like being a frontline healthcare worker, or being a frontline essential worker in other areas like transportation or grocery stores or meat packing, all of which are areas where we've had significantly higher, back to Tyson's earlier point, significantly higher case rates. So those were supposed to be healthcare workers, nursing homes, Group 1A, these other workers I was just talking about, Group 1B, along with people at very elevated ages. Remember, the by far highest health impact of the pandemic. Most hospitalizations are in people over 85, 75, and diminishing risk below that. So that's where a lot of states started. The federal government comes up with the vaccines and has distributed them. The states come up with the precise distribution plans within that guidance. Well, what have we seen happen over the last few weeks? It's turned out to be challenging to get the vaccines to everyone. Even when we can get vaccines to populations like healthcare workers at Duke or a nursing home, not everybody wants to take the vaccine. There are very big differences, including by race and across different groups of Americans in their willingness to take the vaccines. Those differences, the overall trust has gone down in vaccines, and it's gone down particularly in rural populations, and it's gone down in Black and brown populations. I think that's due a lot to the whole nature of the politics we've been having over the past year. You talked about it, DeAndre, at the top of this session. It had an impact. I can say, I was FDA commissioner. I've looked closely at all the data. I can say that I've got a lot of confidence in the vaccines as they've been developed and in the manufacturing process being safe. But after everything that some of these minority communities have been through, they do not have anywhere near that same kind of trust. So education, engagement around the process for developing the vaccines, which again, didn't cut any corners at FDA and did a better job than I've seen in any previous vaccination clinical trial of including diverse perspectives. Not enough for me to say it. We've got to really connect effectively to these to the people who are most affected here and have so many historical reasons to be distrustful. We haven't done that. So what you've seen emerge is a lot of pressure to open up vaccine access more broadly, which when you're in the middle of a pandemic with these, I'm sorry, Tyson, the unprecedented levels of hospitalizations and deaths, why not give out, why should there be vaccines sitting on shelves? So what's the easiest way to give the vaccines out? Well, give it to the people who want them the most. What's the easiest way to do that? Open it up to more groups. And you saw the Department of Health and Human Services announce just yesterday that now they're directing states to vaccinate anybody over 65 and anybody with a comorbid condition, as well as some of these higher risk workforce groups as well. And that is going to help get our vaccine numbers up. If you look at the vaccine numbers, we had a couple million people vaccinated by the end of December, well short of what the government's goals were. A lot of critical press about that. Those numbers have come up. We're now vaccinating well over 500,000, 700,000 people a day, especially as we open up big mass vaccination events at football stadiums or drive-throughs at giant parking lots and all of that. But what's clearly happening along the way is more people in high-risk groups are getting vaccinated, and that's definitely a public health win, is that we're missing people in these high-risk categories. We open up more broadly. The reasons we have enough vaccines to do that is not because we completely vaccinated those highest priority categories, but because we missed some in those groups, and so we're expanding out more. So good news, the more people that get vaccinated, especially in high-risk groups, the fewer hospitalizations we're going to have, the fewer people are going to die. But if you look at who's been missed in those groups and look at the surveys, look at the reports that we're seeing coming in already in terms of where vaccines are available, we have a huge amount of work to do. And this is a really tough public policy problem, because you can't really say in the midst of these very high hospitalization rates that vaccines should sit on shelves or go to waste because they're about to expire, because you can't find anyone else in your hospital who's willing to be vaccinated in a high risk group. But it does just remind us that if we don't really redouble our efforts to reach people where they are and to engage with them around making sure they understand the risks and benefits and can make a truly informed decision about the vaccine and what it means for them and their families, I think we're going to see disparities. I have been pushing for better reporting of data on who's getting vaccinated now, more sharing of that data with the physicians' offices and the federally qualified health centers, the local community-based healthcare that's trusted in each of these communities, so they can see if they've got gaps in their populations. We're going to get that data. I think the new administration is going to push for making more of it available. But the way we're going now, I think you're going to see some big disparities come, February, March, in terms of who's got access. And that's going to translate into differences in cases and all the consequences of that. We have an opportunity right now to really make a determined effort to close that gap, not just by opening up giant mass vaccination centers with the only goal of vaccinating as many people as possible, but putting a lot more resources into education and outreach campaigns to engage communities and meet people where they are, and special ways of getting access for people who may not find it that easy to sign up on an app or drive their car through, a big mass vaccination event in a suburban mall somewhere.
Thank you so much. I love this discussion of doing this work of addressing some of these disparities. And Tyson, I'm wondering, what insights have you found in your work that we sort of this broad we of problem solvers and people interested in health policy, public policy, what can we learn from the scholarly literature here if we're trying to take some lessons for making this better?
Well, that's a big question. I think that, frankly, a lot of things that Mark just said are really spot on. And I think very similarly. I mean, I think that clearly we're in this unprecedented time, right? And these challenges are enormous, but it also brings opportunities, like Mark said. And so I think that the way I've been thinking about this is that, there are sort of incremental COVID-specific interventions that are necessary, as well as these broader, bolder initiatives to sort of ensure population health equity in the long term. And so with respect to these COVID-specific interventions that can be done immediately, I think things like increasing testing and vaccine access in communities of color, making sure that they're readily available, and so you don't need transportation, but meeting folks where they are. You can think about institutions that are embedded within these communities. You can think about perhaps churches as a strategic hub of getting out information, education, and potentially bringing folks together. I think obviously providing economic relief, especially for low-income households, and that would disproportionately benefit communities of color who have significantly lower incomes and less wealth than white communities. And to Mark's point, collecting better data on race and other demographics in order to understand and address COVID hotspots as well as vaccination distribution. And unfortunately, due to these shifting and somewhat replaceable intervening mechanisms, minority communities will likely continue to bear a disproportionate burden of suffering and excess death. This was happening before COVID, it's happening during COVID, and I'm pretty sure it's going to be going on after COVID. And this is going to continue, really, unless structural racism is adequately addressed. And so in order to address the structural racism, a number of scholars have suggested and proposed a range of bold actions, such as criminal justice reform, federal jobs guarantee, financial reparations, universal health care, the desegregation of schools, jobs, and neighborhoods. And this is really consistent with growing recognition that dismantling structural racism through transformative actions across societal domains is essential for achieving population health equity. And I think it also syncs with this growing recognition that economic policies and social policies are in fact health policies, right? Because these are the main drivers of population health. And so I think it's really important to go bold and tackle these large pressing issues that were really magnified and exposed during this pandemic, that have been longstanding issues that are structurally rooted in terms of class and race in America that are driving some of the disparate impact that we're seeing. But I do think that this does raise some new opportunities to address these things.
Tyson, can I follow up on a number of the items that you mentioned as possible policy reforms or policy solutions? The bold ones, are often targeted policies that are really tailored toward a particular group, and those, one might argue, have the capacity to be especially efficient when it comes to sort of marshaling resources to a particular set of targeted individuals, but it might be politically less expedient, or you're much less likely to get buy-in from a broad range of stakeholders, which is typically necessary to enact long-standing policy reforms. So I'd love to hear your thoughts on that, just sort of the political strategy in terms of addressing with policy options.
Oh, wow. Well, that's a big question. Well, there's the rub, right? And so that's always the conundrum, to go targeted and specific, or to have this broad-based neutral policies that are intended to benefit all the population, but may have sort of disproportionate impact on those communities that need these reforms the most. I think that we could look to the criminal justice reform as something something that's been discussed and that's been gaining in sort of popularity. And across the political spectrum, we've seen in the last 10 years, this interesting alliance from both the right and the left, sometimes even working together, these strange bedfellows coming together to try to address, some aspects of the unequal criminal justice system that has a disproportionate impact and disproportionately punitive in poor communities and communities of color. And so I think that perhaps could be maybe that's a roadmap, right? Or a blueprint for getting broad-based support for something that is really critical and important, that has broad, impact across all segments of society, but that ultimately would reduce inequalities along racial lines when it comes to incarceration and other aspects of the carceral state, the carceral continuum, if you will, that we know has such devastating impacts on people's lives, including health impacts. And especially during COVID, we're seeing that, outside of long-term care facilities and nursing homes and things along those lines, that jails and prisons are particular hotspots where where COVID is spreading. And so I think this is really highlighting some of these key inequalities that have really been long-standing and that will only be fixed by these big, bold initiatives. And your question, I'm not totally answering it. But I don't have the answer. Perhaps Mark can weigh in on this as well. Yeah, I don't have the answer, but I do think that these are really important, and I think that gosh, we just got to get it done.
Hear, hear. Mark, any additional thoughts on that?
I just agree with Tyson about the challenges of getting it done and also the importance of getting it done. I guess what I would particularly look to is, we talked about this thing at the beginning, is we are at a kind of a unique legislative time here where the country's coming off, well, still not coming off it, but living through it, and I think kind of hoping to move beyond some of these very divisive issues, including around last week's protests, including everything we all lived through this past year, and the struggles around Black Lives Matter, and a president that really wants to do something about that. And that's been reflected in this way he's structuring his administration, and going out of his way to make sure it's one that connects, that all Americans can see themselves in it. And one where he's had a very bold, broad agenda, an awful lot of things on that list. Well, that's a lot. You got like a 50 Senate with Joe Manchin from West Virginia as the swing voter. That may seem tough, but because we're in a pandemic that has gone so badly for so many people, especially people of color, people in essential jobs, people with limited incomes, it does open some opportunities for some bold thinking. And I think the more that, back to what we asked about earlier, what can we do now that will both help us through the pandemic and prevent this from happening again? A lot of those things that prevent a pandemic from happening again are these so-called upstream for health factors, like exposure to risk and like the factors that cause higher rates of chronic disease. At Duke-Margolis, we've been working with other parts of Duke, the Reach Equity program, others, on ways to make programs for detecting, for disease detection and then rapid response more equitably available. That's very much COVID focused, but the same thing goes for risk factors for cardiovascular disease. The state of North Carolina is in the midst of trying to implement some new reforms in its Medicaid and health programs to integrate them, especially for kids, with the social programs that influence their health, and with, to Tyson's point, criminal justice systems where you can envision a different way of handling kids who have been exposed to serious adverse childhood experiences and potentially get better long-term outcomes. None of these, I agree with Tyson, none of these are going to be easy to solve, but we do have a unique historical time here, thanks to the magnitude of what we've been through, that I think may give people with the right kind of leadership and hopefully some bipartisanship an opportunity to make some real progress.
So we are getting amazing questions from the audience. We have 5 minutes, and so I'd like to propose a lightning round, if I may. So I'll start by throwing it out here without too much preliminary discussion. So for Mark, when people show up to get a vaccine, they're still asked for their insurance information. What happens if you're uninsured? And are certain states or areas with large uninsured populations facing increased issues with getting access to the vaccine?
If you're uninsured, you should be able to get a vaccine any place that is giving vaccines. So that is not all places now by any means. Still very limited supply, and different states are doing it in different ways. So that's the number one thing to remember. Many of the vaccination sites that are being set up now, like some of the ones you've heard about in parking lots and the like, North Carolina, like other states, is starting to use National Guard and other sort of temporary public health workers in special locations. So they shouldn't charge you the vaccines. The federal government's already bought all of them and distributed all of them, so there's no cost there. The administration cost should be covered by these programs. And if it's not, if you get your vaccine at a pharmacy or something like that, there is a mechanism for that pharmacy or that doctor's office to get reimbursed for the cost of administering your vaccine. Now, that said, Doesn't mean it's going to be straightforward. First of all, you got to find a location that you can get to where there is a vaccine. You're probably, at least these days, going to have to make an appointment or be willing to stand in a long line, which is not easy for a lot of people. Hopefully, we're going to get better at that, both with more supply relative to demand and easier and more accessible scheduling and access, as Tyson was saying. Hopefully everybody who's administering the vaccine is going to be familiar with the reimbursement mechanisms, but it should be free for everybody anywhere that people are being offered vaccines.
Thank you very much. Tyson, given the disproportionate impact of this pandemic on populations of color, what does restorative justice look like?
Well, my goodness, I get these big questions. Yeah. So what does restorative justice look like? Well, I think that, yeah, that's the question, right? I think that the opposite of what we have now. So, no, that's my lightning round answer. No, but I think that ultimately that task of dismantling structural racism, right? And this is embedded, as I mentioned, it's multifaceted, it's interrelated, it's institutionalized, it's a system, it's embedded in the culture of our country. And ultimately, that's what's driving these inequalities. And until that's addressed, then we won't have population health equity, which is obviously a goal that I think everyone can get behind, even if they don't always agree on the particular route to achieving that. But I think ultimately restorative justice looks like when we do not have disparities in education and in incarceration and in mortality and access to healthcare. That's when we'll know that we're there. And obviously we've got a ways to go.
Well, thank you. Let's see. I think we have time for this final lightning round question from Andrew. What are your thoughts on the purported Biden plan to release all of the vaccines now instead of holding half of the supply back for the second round of shots? The New York Times noted that it's against the advice of many in the scientific and epidemiological community.
Maybe I'll take that one first from a medical standpoint, and Tyson is very eloquent about putting these in the broader social and historical context. The evidence that we have on the vaccines available now is that you need 2 doses, and that if they're given 3 and 4 weeks apart, respectively, they are very effective in preventing you from getting any COVID symptoms, and especially effective in preventing you from getting seriously ill. So that's the way to take it. That is the current U.S. recommendations. The Biden administration hasn't changed that. I think the Biden administration is just putting a big chip down on the belief that they're going to be able to do just-in-time manufacturing and distribution. So we are expecting more supplies of the vaccines to come forward. So that means instead of like what we did in December was of 20 million doses or 15 million doses, 7 million went out, 7 million were held in reserve, and a few more just in case there was an emergency need or something like that. This would do more like sending out the first 14 million. Well, what that means is by 2 weeks later, you need to get another 14 million to vaccinate the next round of people for the first time, and then start stockpiling enough, start building enough of a reserve that you'll have 28 million by 3 weeks from then. And if you keep increasing vaccine supply further, that means a bigger and bigger supply. They need to make sure that they've worked out something like that logistics. I think it's okay if you can't get your vaccine exactly 21 days after you got your first Pfizer shot, but I don't think there's a good public health reason to design a plan that means you can't get it by 4 weeks or 5 weeks or 6 weeks after. So I think we'll see. They may end up modifying that plan. And again, just the final thing, I know we're at time, sorry, but that I add in here is that the more we give the vaccine supply out now to everybody to more of the all comers, it's really the people who most want the vaccine. So the ones who are responding, yes, I want it in the survey, and have the easiest path to getting to that drive-through or getting to that vaccination site, they're going to tend to get vaccinated. So we have to pay extra attention to helping those who can't.
Thank you so very much. And we've got with us tonight Professor Mark McClellan, who's the Robert J. Margolis Professor of Business Medicine and Policy and the founding director of the Duke Margolis Center for Health Policy at Duke University. We also have with us tonight Professor Tyson Brown, who is an associate professor of sociology and the director of the Center on Health and Society. We are so just grateful for your time tonight and for these insights. Thank you so much, Professor Brown, Professor McClellan. And we hope that you will join us again in 2 weeks for the next Polis event. We're having a seminar you won't want to miss with Professor 𝗣cie𝗹𝗶𝘁𝗲 and Professor 𝗣cie𝗹𝗶𝘁𝗁, who will talk a little bit about financing, our efforts to address the COVID-19 pandemic. So that'll be on January 27th. So please stay tuned for more information, and we hope you will have a wonderful evening. Thanks so much, everybody.
Thank you.
Thank you for having us.